Okay, for this lecture, we are going to cover spongiotic reaction pattern and psoriasiform reaction pattern. So we'll start with spongiotic. Now, the prerequisite for this lecture is obviously going to be normal skin histology. So you have to understand normal skin histology as well as just the way the epidermis looks when it's not spongiotic or when it's not psoriasiform. Um, and just to identify where the inflammation is happening is going to be key. So please review the video on normal skin histology just to prime you for this lecture. So what is spongiotic dermatitis? Spongiotic dermatitis is really defined by intercellular edema between epithelial cells. It appears as widened intercellular spaces. And when that happens, you can see the cell-to-cell connections very well. So the cadherins, the desmosomes, everything is more pronounced. You can actually see these spiny connections in between the keratinocytes with all of that edema there. And we'll show you the classic picture of that. So desmosome spines can be seen very pronounced, a little bit subtly up here at the top, but then even more so in the middle of the picture. Now, lymphocytes are obviously, going into the epidermis, they could represent something bad like cutaneous T-cell lymphoma. But usually, when you have these normal appearing lymphocytes within a spongiotic epidermis, that's the result of exocytosis. And that happens kind of just by second nature with the inflammatory process. So many times you will see lymphocytes hanging out in areas of spongiosis. Now, if there's strong clinical concern for a cutaneous lymphoma, you should still do some stains just to make sure that these are not heavily CD4 positive and they lack CD7 and CD5 and that there's no clonal proliferation, because you can have spongiotic variants of CTCL. But that being said, most of the time, and especially for exam purposes, if you see this much spongiosis, it's not going to be classic for mycosis fungoides. A little bit more about spongiosis. So it's almost always accompanied by normal appearing lymphohistiocytic infiltrates around the superficial blood vessels in the dermis. And as I just mentioned, lymphocytes within the epidermis, and that's called exocytosis. You can contrast the term exocytosis with the term epidermotropism, which refers to honing of atypical, clonal, or malignant lymphocytes into the epidermis. That's epidermotropism. Now, epidermotropism also can refer to other types of malignancies having an affinity for the epidermis. So certain types of malignancies may migrate to the epidermis. You can think of things like an underlying malignancy in secondary extramammary Paget's disease or some adenocarcinoma making its way to the skin. So unfortunately, spongiotic dermatitis has many overlapping histologic features with psoriasiform dermatitis. What does this translate to in the real world? It translates to real world specimens often looking like a mix between psoriasiform hyperplasia and chronic, subacute to chronic spongiotic dermatitis. And a lot of that is because we get biopsies of partially treated psoriasis, or we get biopsies of things that look clinically like psoriasis, but it's actually just a subacute to chronic eczematous process going towards Lichen simplex chronicus. And there are some helpful clues, but sometimes we have to describe exactly what we're seeing. And then if we don't have enough clinical information, we're going to have to rely on the clinician to put it together. But there's no harm in describing exactly what you see and then putting what your favorite diagnosis is or what you prefer in the comment. So this is mainly just for your self-reference. We will hit upon all of these, but spongiotic dermatitis can be classified into acute, subacute, or chronic. And the list below represents many common entities that have spongiotic dermatitis on their actual inflammatory pattern. And so being able to say specifically what the diagnosis is when you see a spongiotic reaction pattern is going to be difficult unless you have some good clinical information, and there are some other helpful hints that can really put you more towards the accurate diagnosis. But In some cases, you really just have to sign it out as spongiotic dermatitis and describe what you're seeing, and then based on the clinical history, give them your favorites. So let's start out with acute spongiotic dermatitis. Acute spongiotic dermatitis is defined by a prototype, where the prototype is actually allergic contact dermatitis because it demonstrates it very well. What you'll see are these very noticeable large spongiotic vesicles within a background of a spongiotic epidermis. You'll often see this basket weave or orthokeratosis stratum corneum on top, which indicates that this is more of an acute process. So this epidermis hasn't really even had time to try to repair and make a lot of parakeratosis on top. This is really an acute edema of the epidermis. And so that will signify to you. The other thing is with these microvesicles, you'll often get Langerhans cells kind of collecting and hanging out. Remember, Langerhans cells' job is to collect some antigens and develop into antigen presenting cells ready to present to the immune system, to train the immune system to fight off whatever is causing this issue. And so what you'll see in acute spongiotic dermatitis is really defined by these microvesiculation with overlying acute stratum corneum. And the picture clinically that you'll get often are bullae too. So the spongiotic vesicles get so dense sometimes and confluent that they'll actually cause a blister to form with the fluid leaking out subepidermally. So you can actually see some tense bulla here, some small vesicles. Depending on how robust the contact antigen was, you'll see varying responses. But here, you know, she may have come into contact with a plant. She may have come into contact with some metal, some jewelry. There's many different causes of allergic contact dermatitis. The key here is to recognize acute spongiotic dermatitis and how that correlates with something clinically. As with most rashes in dermatology, they have a characteristic intense pruritus. As I mentioned on histopathology, you'll see that normal basket weave stratum corneum with prominent spongiosis, spongiotic vesicles and bulla, papillary dermal edema, and variable superficial perivascular infiltrate, lymphocytes plus or minus eosinophils. And I really want to emphasize the plus or minus eosinophils here, because a lot of people think you have to have eosinophils to have an allergic disease or a drug reaction or something of that nature. But eosinophils, although they can help push you one way or the other, if you have a lot of eosinophils, you can think, yeah, it's probably more allergic. But if you don't have eosinophils, it doesn't mean that you don't have a drug reaction. It doesn't mean that you don't have a contact dermatitis. So eosinophils are nice when they're there, but they're not always required for these diagnoses. The other thing is that eosinophils can be very helpful to help you exclude a pure autoimmune connective tissue disease. So if you have a lot of eosinophils, then it kind of argues against a pure autoimmune connective tissue disease such as lupus or dermatomyositis, for example. Now, there are exceptions, including drug-induced lupus, but we won't get into that in detail here, because unless you're really suspecting a drug-induced lupus, you're not going to get hung up on that. So the other thing is that classic psoriasis often does not have a lot of eosinophils. And again, the exception is drug-induced or TNF-alpha-induced psoriasiform dermatitis, a TNF-alpha inhibitor-induced psoriasiform dermatitis, which is a paradox because the whole point of that is to try to treat psoriasis, but sometimes it can actually cause a worsening of psoriasis associated with eosinophils. So beyond that exception, classic psoriasis vulgaris usually does not have abundant eosinophils. So in this scenario where you're seeing epidermis with a lot of psoriasiform hyperplasia, but you see a lot of eosinophils, the patient's only on topicals for their therapy, you can start to imagine that that's probably just a subacute to chronic spongiotic dermatitis and not a classic psoriasis. So eosinophils can be helpful. So we went over this picture and just more pictures to show you how prominent the spongiosis, how prominent those vesicles can be in acute spongiotic dermatitis. Now, sometimes you don't see an overlying vascular stratum corneum because it's really just kind of covered up by dense serum-containing crust. Again, a lot of this fluid will end up leaking out of the epidermis. And so the spongiotic vesicles are key. Now, practically, this can be confused many times with a pustular psoriasis, especially if it's on the hands. But usually with pustular psoriasis, you're going to want to see much more neutrophils in the spongiotic vesicles, in the vesicles. And in the spongiotic vesicles, you're going to want to see more lymphocytes and histiocytes, not as many neutrophils. That can be one helpful hint. If you also have a lot of neutrophils in these vesicles and you have surrounding psoriasiform hyperplasia to the adjacent sides of the vesicles, that can also argue more towards a psoriatic pustular psoriasis. Now, the other helpful hint that I mentioned was if you have a lot of eosinophils here, it's going to make you think more about acute spongiotic dermatitis. If you have absolutely no eosinophils, then it doesn't necessarily help you. But if you are trying to figure out psoriasis or not, and you do have a lot of eosinophils, it argues against psoriasis, so it will help you. Moving on to subacute spongiotic dermatitis, erythematous plaques, often with wet scale, so they're still evolving from an acute flare, and now these patients actually are having lesions that come and go or that stick around, not completely resolving, but haven't yet turned into a Lichen simplex chronicus. So subacute spongiotic dermatitis is actually the most common spongiotic dermatitis that I sign out. It's characteristically pruritic, so they are scratching a lot. There are numerous entities such as atopic derm, nummular eczema, contact dermatitis that all can exhibit subacute spongiotic dermatitis. So clinically, you'll see these kind of scaly, erythematous, eczematous looking plaques, papules that coalesce into plaques. This is just a really undifferentiated rash most often that we need biopsies to demonstrate. Are we dealing with a subacute? Are we dealing with some type of interface? Are we dealing with a psoriasiform process? Are we even dealing with a cutaneous lymphoma? I mean, there's many mimickers here. Sarcoidosis, syphilis, there's so many things that can look like a scaly erythematous rash on the skin. So for new patients that are coming in, I like to get a biopsy to really establish what their untreated disease looks like. And it's hard to actually biopsy untreated disease unless the patient confidently tells you, I haven't been putting any treatment on this area. But try to get a biopsy of an untreated area because that gives you the purest picture of the pathology. So what are you going to see in subacute spongiotic dermatitis? You're going to see parakeratosis and you're going to see mild epidermal hyperplasia, but not psoriasiform hyperplasia most often. And you'll see hypogranulosis sometimes with intermittent hypergranulosis. Now, hypogranulosis should trigger in your mind psoriasis. Usually psoriasis will completely lack the granular layer confluently or be very low with their granular layer. But just the presence of hypogranulosis usually corresponds with overlying parakeratosis. So that's normal. And you can see that in subacute spongiotic dermatitis. It doesn't define the entity, but it's something that you can see. But complete loss of the granular layer with overlying intracorneal neutrophils, that would help put you more towards a psoriasis, okay? If you do have a lot of intracorneal neutrophils, but it doesn't look like psoriasis to you, you always have to do a GMS to make sure that the clinician didn't biopsy fungal infection. They're not always going to scrape it, so we don't oftentimes have the ability or the efficiency to scrape every scaly lesion, but we sometimes also want to just biopsy the patient and have the pathologist do a GMS stain or a PAS stain to look, because sometimes the KOH is not going to be representative of the true pathology, depending on your scraping sample and things. So it's really nice to be able to get a biopsy and make sure that, first of all, it is a spongiotic. Second of all, that it's negative for fungus, at least on the biopsy. It's important to have biopsies that contain scale so you can really capture fungal infections if they are present. Spongiosis, obviously in subacute spongiotic dermatitis, but it's less prominent in terms of the vesicle size than acute spongiotic. Variable superficial perivascular infiltrate, that is a very non-specific feature that you can see in many different inflammatory entities in derm paths. So it's useful to describe it when it's there. It's useful to say it's mild, moderate, or severe perivascular. And it's also important to note if you do see eosinophils. And as you go along the timeline of acute, subacute, and chronic, you get less dermal edema, you get less pronounced spongiosis with time. So that's important to keep in mind as well. So for subacute spongiotic dermatitis, again, you see some areas of increased edema, you see some overlying intermittent perikeratosis, some fibrin in the crust, acanthosis, so it's got time to actually be hyperplastic here. And then some perivascular inflammation. This was actually a biopsy of atopic dermatitis. Just another higher or medium power view of the spongiosis here. You don't see really large microvesicles here. You don't see those large spongiotic vesicles that we saw in acute. You'll see that perikeratosis and its underlying hypogranulosis. And then adjacent to it, you have compact orthokeratosis with the return of the granular layer. Notice the lymphocytes, which are exocytosing into the epidermis. And moving on to chronic spongiotic dermatitis. So chronic spongiderm is many times with chronic exposure and chronic pruritus and scratching, mechanical stimulation of these areas that ultimately result in lichenified papules and plaques on the patient's skin. Here you see very lichenified areas in the popliteal fossa, on the ankle here. You can understand why somebody, especially in maybe a skin of color, may think this could be a discoid lupus or a psoriasis. It's unclear, but definitely getting a biopsy to help you figure out between lupus, psoriasis, and lichen simplex if they're not responding to treatment, if the patient really wants to have more data or evidence to help formulate a working treatment plan. I've actually had patients on Dupixent respond extremely well. Nothing was helping their lichen simplex chronicus, and they got on Dupixent and it cleared up and their life changed for the better. And that is not an official endorsement of any company. I'm just saying that dupilumab is definitely helping a lot of these patients with chronic eczema. Chronic spongiotic dermatitis is usually characterized by hyperkeratosis and focal perikeratosis. You can see the irregularity of the granular cell layer, but most of the time you have hypergranulosis because you have so much hyperorthokeratosis. That hypergranulosis oftentimes will get 6-7 cell layers thick. Now here it's not fully evolved yet, so it's still kind of in that 2 to 3 cell layer thick stage for your hypergranulosis. But really chronic lichen simplex chronicus will have very thick orthokeratosis and 7, 8, sometimes 10 cell layers thick of the granular layer. Also, you'll have irregular epidermal hyperplasia. That'll help you determine that it's not a psoriasis. You'll see minimal spongiosis and variable superficial perivascular infiltrate, as well as dermal fibrosis, because the dermis starts to produce more collagen with the mechanical stimulation that keeps occurring. And so what your skin is trying to do is really strengthen itself against the external pruritus trauma, the external scratching secondary to pruritus rather. So here you see jagged, irregular hyperplasia of the epidermis. You see some vertical collagen orientation. We call that vertical streaked collagen. And the epidermis contains this overlying hypergranulosis and compact or even just hyperorthokeratosis here. Sometimes you'll get intermittent perikeratosis. You'll get some serum containing crust on top if it's been excoriated freshly. You'll also notice that a lot of these suprapapillary plates are quite thick. Now, some of them get a little thin here, but most of them are not thin. You'd expect psoriasis to have untreated classic psoriasis that have all these thin suprapapillary plates going across. So that's a contrast that can be helpful. What are the clinical subtypes of spongiotic dermatitis? They include things like eczema, as is commonly used. But when we say eczematous, we usually mean that something's like weeping or it's inflamed. But if we say eczematous, what we're really trying to say is it's not a connective tissue disease. It's not psoriasis. It's not a lichenoid interface. It's not a vacuolar interface. This is an eczematous process. This is what we refer to as a group of diseases like atopic dermatitis, nummular dermatitis, irritant or allergic contact dermatitis, dishydrotic eczema, Lichen simplex chronicus, or prurigo nodularis, even Stasis dermatitis. So these are entities we will just briefly discuss here. So if you're a dermatologist or a dermatology resident, or a dermatopathologist in training or in practice, we all know very well atopic dermatitis. So atopic dermatitis is a very heterogeneous disease. It's not really defined by a single classic presentation every time, because patients can present very differently, and patients can actually have secondary infection overlying their eczema as well. But you're expected to just be able to recognize that most young kids that have erythematous weeping plaques on the face, lichenified areas due to secondary chronic pruritus and scratching on the popliteal fosses, the antecubital fosses, anywhere on the body really, with just chronic pruritus, that you're going to need to be able to recognize that this is most likely eczema. And if the patient wants to give a biopsy to really solidify that, or the patient's parents wants to obtain a biopsy to solidify that diagnosis, that is fine. But most of the time as clinicians, we treat this as eczema and we do our best to get it better. And if it's not really responding, then we start thinking about getting a biopsy of it. But children are not the only patients that get atopic dermatitis. In fact, young adults as well as older adults can get atopic dermatitis. And what is the cause of that? So it's really due to a lack of skin barrier function being optimal. So with impaired skin barrier, which can be caused by a variety of things, it could be caused by a lack of protein production that's normal for the skin barrier. It could be caused by aging and decreased natural moisturizing factors. It can be caused by a contact dermatitis that set them off and they've never been able to recover. But with that lack of moisture and with the chronic inflammation and itching, there's a vicious itch scratch cycle. And for the patients to be able to escape that, we have to treat their eczema or their atopic dermatitis, no matter what age they are. So use the example that we've had patients who failed topicals at all ages. We've done biopsies that showed spongiotic dermatitis, and we got them on either topical medications or systemic medications that were able to get them under control. And the focus of today is not the treatment therapies of eczema here. It's just more of the diagnostic aspects of it. So we will defer a deep discussion on the treatment. Now, the other thing is these patients often have weeping, excoriated, or actually loss of epidermis overlying their rash. And staph loves to grow in all of those growth factors. The staph bacteria loves to thrive in eczema skin. And so having an ability to not only treat hydration and inflammation, but also to reduce the bacterial burden is going to be super important for the treatment of eczema. You can see very diffuse lichenified plaques here on this patient with type 4 to 5 Fitzpatrick. So atopic dermatitis in its early phase displays mild spongiosis and exocytosis of lymphocytes with parakeratosis. Eosinophils are usually not that noticeable compared to allergic contact or nummular dermatitis. And as atopic dermatitis evolves, you start to see elongated reedy ridges with less prominent spongiosis and inflammation, as well as overlying hyperkeratosis with intermittent parakeratosis. And this may progress to lichen simplex chronicus. Oftentimes it does. At least a few areas on patients with chronic eczema will have some lichen simplex chronicus. This is just a basic subacute spongiotic reaction pattern that we've already discussed. Nummular dermatitis is really all about the morphology clinically. So you should just recognize these pruritic coin-shaped or nummular erythematous scaly plaques with chronic course and unknown etiology commonly affect the extremities, especially the extensor surfaces. Nummular dermatitis is really defined by these coin shapes. Now, on biopsy, you're going to see spongiotic dermatitis. You're not going to be able to say it's nummular. You have to rely on the clinician to make that correlation or to tell you, or you have to see photos of it. You could imagine many great mimickers of this clinically. So you could be looking at psoriasis that's been partially treated. You could be looking at a fungal infection. You could be looking at some form of just secondary prurigo change. It looks like there's some fresh excoriation here with overlying, you could have post-inflammatory pigment alteration. Within all this, you can have secondary infection, and you could have mycosis fungoides or sarcoidosis here. You could have syphilis here. So biopsying to really rule out spongiotic derm or rule it in is going to be very helpful just to make sure you're not missing anything serious. As I said, nummular dermatitis is usually subacute spongiotic dermatitis with mild to moderate spongiosis, usually minimal vesiculation, irregular acanthosis with some exocytosis of lymphocytes, perikeratosis with aggregates of coagulated plasma, mild papillary dermal edema with vascular dilatation, and superficial perivascular infiltrate with lymphocytes. You can have some eosinophils, it's not always required, and occasional neutrophils. Again, if you see neutrophils in the stratum corneum, it's pretty much imperative to make sure that you get a fungal stain on that, unless the clinician was absolutely not concerned about fungus at all. But still, even if not, because fungus is easily missed sometimes in skin rashes. Treating the fungus is going to be important to resolving the spongiotic dermatitis. Here's another classic subacute spongiotic dermatitis pattern for you. Again, more of the same at this point. So it's becoming repetitive now. Actually, it was becoming repetitive before because, again, the takeaway here is the spongiotic reaction pattern is representative of many different types of eczematous processes here. You can see a nice it may have been a spongiotic vesicle that kind of ruptured and has had time to fill up with blood here and serum containing crust. But this is a pretty subacute and it's kind of evolving into chronic because look how hyperplastic the epidermis is. And you could get really into thinking that this is a psoriasiform hyperplasia, but you'll notice these suprapapillary plates are quite thick. You'll also notice some really good areas of preservation of the granular layer. And there's not a really great amount or abundant amount of neutrophils here. This is in a thick stratum corneum. And if you go in higher power, you'll probably find more eosinophils to argue against the psoriasis. Allergic contact dermatitis, we already hit on that. I will kind of let you read this slide on your own here. I won't read it word for word, but the most important thing is to remember it's a type 4 delayed hypersensitivity reaction. The most common causes include things like nickel, balsam of Peru, fragrance. These are things that when you're interviewing a patient, trying to figure out what caused it, you need to go through systematically and say, do you use a lot of fragrance chemicals, whether it be soaps, shampoos, perfumes, detergents, candles? Try to understand how much fragrance do they really get exposed to? Do they wear jewelry? Did they change their diet at all? Because balsam of Peru can be present in many different types of foods and drinks. Are they putting on any special topical creams or cosmetics or medicines? These just kind of going into this. And then ultimately, if you suspect that there could be an allergic contact dermatitis, to get them patch tested, because we can really correlate what their skin's reacting to with some of the most common allergic contacts. And so there are very wide panels that can be done at specialized places that are in tune for contact dermatitis testing. And if the patient is not identified on the initial screens of patch testing, it's good idea to refer them to a place that's more advanced that can test even more In Oklahoma, we refer a lot of our patients to the Oklahoma Allergy and Asthma Clinic to do the patch testing as well. And where I trained in Miami, we had a very extensive patch testing clinic. So we were able to test for probably close to 100 different, or maybe over 100 actually, different causes of contact dermatitis. And if you do find a culprit, then you can actually go to the Contact Dermatitis Institute and print off a list of things to avoid. The patient actually has concrete products that they can avoid. So it's very important as the dermatopathologist to let the clinician know, yes, this could definitely be an allergic contact dermatitis. And that's where the pathology comes in to help the clinical. But of course, sometimes you don't need pathology. It's pretty clear that a necklace overlying the neck here, necklace probably had some nickel in there, and it caused just a geometric distributed allergic contact dermatitis. You can also have allergic contact dermatitis to plants, such as poison ivy, poison sumac. It can get really robust and have these very tense bulla here. If you were just shown a picture and you had to kind of go through your process of elimination to choose the best answer on an exam, if you see a linear geometric distribution, then allergic contact should be going really high up on your list. As I said, the histopathology includes acute spongiotic dermatitis plus or minus eosinophils. If not acute, you can look identical. If it's not acute, it can look identical to atopic and nummular dermatitis. The clue to differentiate, I find it helpful, is if you find more Langerhans cell microabscesses and you find more eosinophils, that can help push you more towards an allergic contact compared to some of the other more common spongiotic dermatitis entities. So here is a really great example of a Langerhans cell microabscess. Here's a coffee bean. I had my espresso shots this morning, so I love my coffee beans here. And we also like seeing coffee beans within the derm path. So just keep in mind that if you see a coffee bean shape, you can be thinking about Langerhans cell microabscesses, as opposed to vesicles that have cells that have more of a cerebriform shape to them, a cerebriform nuclei. Then when you see something like that, you're going to be thinking more about Pottier's microabscesses and mycosis fungoides. But moving back up to allergic contact here, if you just had spongiotic change and you didn't have this big Langerhans cell microvesicle and you didn't have a lot of eosinophils, then it could still be contact dermatitis. But if you're able to capture some allergic contact, or sorry, if you're able to capture some Langerhans cell microabscesses, and if you're able to see a lot of eosinophils and the clinician suspecting allergic contact, it all fits pretty well. So you would definitely want to emphasize that in your report, that yes, this is very consistent with allergic contact dermatitis. If you see a clinical and it's geometric, then you pretty much have no doubt in your mind. Allergic contact dermatitis on pathology can show acute, as we mentioned, but also subacute and chronic changes if the patient's constantly being exposed to the same antigen over time. And so here you had the pathology had enough time to get pretty acanthotic and still retain a lot of moderate to pretty severe spongiosis here, but no micro or no large spongiotic vesicles. Overlying hypergranulosis, overlying orthokeratosis. This could be on an acral site, so you get a lot of thick stratum corneum. You'd have to go to the sides to compare the normal thickness of the stratum corneum to get a better idea, but this could be in the realm of acute subacute allergic contact dermatitis on the hands, for example, on the feet, or it could just be secondary to a lot of prurigo change. That's why you're getting that thick hyperorthokeratosis. Moving on to photo-induced reactions. So photoallergic reactions are referring to cell-mediated hypersensitivity to an allergen that was activated or produced by the effect of light. The light actually acts on maybe a drug, for example, that's within the circulation that's made its way into the skin. And the UV light is required. That's what defines a photoallergic reaction. The UV light is required to convert drug into immunologically active compound. But unfortunately, the reactions are idiosyncratic and they can be maintained even in the absence of that excessive sun exposure. So It's unfortunate that some photoallergic drug reactions are going to start with photo activation, but are not necessarily going to go away even if the patient stops getting a lot of photo exposure. So that can be a little bit frustrating, not only diagnostically, but therapeutically. And we'll kind of recognize that this is one of the most difficult entities to diagnose and treat, especially if it's not cleanly photo distributed and they're getting id reactions across the rest of their body. But if you see a really clear photo distributed rash, you need to be thinking about a photoallergic or an autoimmune connective tissue disease at least. Photoallergic reactions, the common culprits include thiazide diuretics, as well as sulfonamide antibiotics, sulfonylureas, and phenothiazines. These all contain sulfur moieties. The clinical, of course, you're going to see in sun-exposed sites, pruritic papules and plaques resembling dermatitis, more chronic than phototoxic eruption. So phototoxic is the it's related to photoallergic, but it's different because at that point, what you have is a direct toxin that causes not necessarily an immune response, an immune stimulation or type 4 response. It's more of a direct necrotic effect on the cell. It's more of a direct cytopathic effect on the cell. That's why it's called phototoxic and not photoallergic. And you would see different things in pathology, which we'll mention. Chronic exposure to photoallergic drugs can lead to extreme photosensitivity that unfortunately lasts months to years after the responsible drug is eliminated. Photoallergic reactions include, on the histology, very similar picture to allergic contact dermatitis. So if the clinician gives you a photoallergic versus allergic contact, well, you're going to have to ask them to clinically correlate with the medicines the patient's on, the distribution of how it's actually presenting. If you have access to the EMR and the images, you can do the investigation yourself and see how they documented it, how the patient presented, and help you differentiate those two. But if you don't have enough clinical information, you can still say that it could be an allergic contact or a photoallergic, depending on the clinical scenario. You'll see spongiosis, mild acanthosis. You'll see superficial perivascular lymphocytic infiltrate with eosinophils. You'll see some Langerhans cell microabscesses, all the things that we mentioned in allergic contact. Here's another example of that, spongiosis of the epidermis. You can have spongiotic vesicles. The other thing with photoallergic reactions, especially chronic, is you'll start to see some melanin capping due to photoadaptation. So the keratinocytes are going to start kind of putting that melanin on the caps of many different cells. And this is not a great picture to show an example of that, but in entities that are induced by UV irradiation, you're going to be able to see that melanin capping even more diffusely. Moving on to irritant contact dermatitis. So this is due to a direct irritant effect that causes erythematous, eczematous papules and plaques. It's the most, it causes the reaction in most individuals who come into contact with it. So you don't have some underlying allergic predisposition here. Pretty much anybody who comes into direct contact with an irritant contact is going to get this irritant contact dermatitis. It could be due to the effect of acids, bases, or other chemicals that are irritating to the keratinocyte cell biology and the structure of the skin. More common than allergic contact dermatitis. And again, that's because you do not require an underlying predisposition to develop this. Hand dermatitis, that's where you have excessive washing or antimicrobial foams, gels, things that occupations that require patients to work with a lot of chemicals, to wash their hands a lot. You're going to see this in that population. Diaper rash is another form of irritant contact dermatitis caused by just the irritant effect of urine and feces on the skin itself, and just being contained in the diaper and then sticking onto the skin and irritating the skin. You're going to see a lot of diaper rash happening in young kids. So here you see irritant contact dermatitis. This around the mouth could be caused by many things, like it could be caused by lip licking, for example. So just a mechanical stimulation of constantly licking the lips, and then some maybe overlying superimposed bacterial infection here. You can see the irritant effect of diaper rash and also just the irritant effect of something that the patient was being exposed to on the hands. On histopathology, you're going to see that typical spongiotic dermatitis. The clues to differentiate compared to allergic contact, you're going to see more necrotic keratinocytes in irritant contact. You're going to see that toxic effect of the external irritant with some changes even to the nuclei of the cells. So you're going to see more karyorrhexis, more cytoplasmic pallor, more acantholysis, and more neutrophilic infiltration. So these are some clues to help you differentiate. Here is just kind of a review of what you could potentially see in the cell. So for karyolysis, you're going to actually have this nuclear fading here. You're going to see little fragments of the more basophilic or hematoxylophilic staining here. And what happens in karyolysis is chromatin dissolution due to the action of DNases and RNases, okay? Pycnosis is where you have nuclear shrinkage. The DNA condenses into a shrunken basophilic mass. And karyorrhexis is where you have nuclear fragmentation. So pycnotic nuclei, membranes ruptures, and the nucleus undergoes fragmentation. This all leads to nuclear dissolution, and this leads to an anuclear necrotic cell eventually. But you may capture many different phases of the keratinocytes here after direct toxic, and even with apoptotic changes as well. So we'll usually say like dyskeratotic or apoptotic, but usually with apoptotic cells, you'll find just really hot pink cytoplasm, and then these kind of nuclear changes here. You can see this hot pink cytoplasm coming in. It almost looks like the same color of the dermis here. It can be even more hot pink or bright pink than this. And this is due to an irritant contact dermatitis. So you see this just overall unhealthy look to the epidermis here. It's bordering on some full thickness necrosis in some areas too. So that direct toxic effect. Here you can actually see an area that looks like more full thickness necrosis underlying the basket weave stratum corneum here. And remember, the stratum corneum is composed of dead keratinocytes already, anucleate dead keratinocytes. So you can have preservation of the architecture here of the stratum corneum. But what the striking pathology is here is this just really diffusely necrotic epidermis. Now, not all irritant contact dermatitis look like this. In fact, if this looks a lot like nearing a Steven Johnson or toxic epidermal necrolysis because it's full thickness here. But look to the left, you'll see kind of a demarcation of where that irritant contact really had its effect, because there's a lot of pretty close to viable keratinocytes over here. The nucleus is still intact, at least on the left. Some more examples of some direct toxic effect in the background of spongiosis. All right, moving on to dishydrotic eczema. Clinically, you're going to see recurrent, severely pruritic, deep-seated vesicles, symmetrically distributed on the hands and feet. Classically involves the lateral aspect of the fingers. Differential diagnosis includes, as always, bullous dermatophyte infection. So if a patient has little vesicles and bulla on their hands, you definitely want to do a KOH or at least biopsy it and send it off to get a GMS or a PAS stain to rule out fungal infection. Because the treatment for dishydrotic eczema involves steroids, and if you put steroids on a fungal infection, it's going to get worse. So you definitely want to make sure you're absolutely dealing with dishydrotic eczema. You can do a trial of antifungal. If it doesn't get better, then that kind of gives you your answer as well. So here's a more classic presentation of dishydrotic eczema as these tapioca pudding-like vesicles. Picture of the tapioca pudding here so you can appreciate the similarity. Of course, it can be very robust. So here it's starting to look like a bullous dermatosis. You've got very large tense bullae here on the palm. Histology, of course, you're going to have acute spongiotic dermatitis if it's more acute. The clinical impression is critical here. You can see discrete intraepidermal vesicles with thickened stratum corneum and papal skin, some spongiosis, superficial perivascular inflammation. You should always do a PAS or a GMS because tinea may mimic dishydrotic eczema histologically. Here is dishydrotic eczema. And again, the clinical that we often get is dishydrotic eczema versus bullous tinea versus pustular psoriasis. So here, I don't view this as a classic psoriasiform hyperplasia to the side. So that argues against a pustular psoriasis. I don't see abundant neutrophils here. So that argues against a pustular psoriasis. And if I saw some eosinophils in the dermis, that would also argue against a pustular psoriasis. We can easily do a GMS here and rule out a PAS or a GMS to rule out presence of fungal organisms. And what we'll be left with here is dishydrotic eczema is the most likely. If the clinician was between the three entities I just discussed, we would be able to help rule out two of those entities and help rule in dishydrotic eczema. Just another picture illustrating the same thing. Just a brief word on dermatophyte infections. So dermatophyte infections can cause a spongiotic dermatitis. And so unless you really are able to visualize the hyphae on histology, which can be really difficult sometimes, especially if you don't have a ton of organisms, but you have enough to cause disease, then you're gonna have to do a stain to really rule it out. So many times reports will be signed out as spongiotic dermatitis, and then an addendum will be reported to confirm it was negative for GMS. If the or GMS or PAS to show positivity or not. If it was positive, then the diagnosis would actually change into dermatophytosis, and the spongiosis is a result of the dermatophytosis. So here, clinically, you'll see well-demarcated scaly papules and plaques. You'll see scale usually on the edge, the leading edge of the plaque itself, where the fungus is just kind of growing and spreading out here. Now, this is kind of an annular configuration, and so there's many different things that can give you annular configurations. Clinically, sometimes it can be difficult to tell if you're dealing with a nummular dermatitis or a tinea or even an annular or figurate erythema. It can be difficult sometimes to know if you're dealing with a subcutaneous or a subacute cutaneous lupus, or even a granuloma annulare can sometimes look like this. Erythema annulare centrifugal. These are all reasonable suspicions. Even here, this erythema gyratum repens can look very similar to this picture over here. So biopsy is going to be key to really establish the diagnosis. More examples of tinea. This distribution here on the face and beard area is pretty classic, but you can understand why somebody might think of a granuloma annulare if this were in a different part of the body, because of this really kind of elevated erythematous. It almost looks like the pathology would be more in the dermis and not necessarily in the epidermis. However, if you go on higher inspection, you'll be able to see that there is some scale here. But biopsying this edge here and ruling out tinea is going to be helpful if you don't know the diagnosis here. So the good thing too is if you see spongiotic dermatitis and you see that reaction pattern, you'll immediately know it's not granuloma annulare if you don't have a proliferation of histiocytes in the dermis, palisading around necrobiotic collagen. So we'll get to that lecture here as well. Dermatophyte infections include on histopathology a special type of sign. It's called a sandwich sign. I'll bring your attention down here to this blue word here, sandwich sign, where the fungi are often sandwiched between two zones of cornified cells. So you've got the upper zone, which is orthokeratotic. The lower zone is perikeratotic. You can have variations on this theme, but the important thing is if you're seeing a spongiotic dermatitis and you're seeing intermittent perikeratosis with alternating orthokeratosis, or even vertically noticing a change there, it's going to be important to make sure that you're not looking at a sandwich sign. So just do a stain for GMS or PAS to make sure. But of course, you can have acute, subacute, or chronic spongiotic dermatitis and dermatophyte infections, because depending on how long the patient's had it, right? And they itch, so they're going to actually have superimposed prurigo changes on top of this as well. Often neutrophils are present in the stratum corneum. Again, like I said, you're going to want to rule out the fungal infection when you do see neutrophils in the stratum corneum. So here you see just a mildly spongiotic dermatitis here, a little bit of acanthosis, nothing crazy. It's not very inflamed. But the tip off here is the perikeratosis, overlying orthokeratosis. And sometimes if you were to do a GMS stain on this, it should come back positive if it's dermatophyte infection. But if you weren't doing a GMS on this, or if you did a GMS on this or a PAS and it was negative for fungus, then you can think that this actually represents maybe a resolving process, a spongiotic dermatitis that's improving, and the perikeratosis is on its way out. So this is sometimes known as the last week sign. It's also known as the sandwich sign, but the take home is you definitely have to, I've said it enough, do a GMS or a PAS to rule out fungal infection. Dermatophyte infection, again, can look exactly like dishydrotic eczema. So, and that's because the prominent spongiosis and inflammation that is happening in response to the fungal infection. Again, these Langerhans cells are getting upset and they're going to start accumulating in spongiotic vesicles. They're going to try to get some antigen to present to the immune system. So it looks pretty much identical in many cases, but when you do a GMS or a PAS, you're going to be able to find the dermatophyte organisms. Here's more dermatophyte infection examples, just showing you spongiotic dermatitis. You might appreciate these neutrophils in the stratum corneum here and some serum containing crust. So no one would blame you for not seeing organisms on this, but someone could blame you for not doing a GMS on this, even if the clinician didn't suspect fungus. So when in doubt, do a GMS just to rule in or rule out fungal infection. Here is a PAS highlighting some of the hyphae up in the stratum corneum here. So you just see these organisms right up in the stratum corneum. They're not doing much below that. And like I said, you just have some mild spongiotic change, not even that much inflammation here. Another example of a PAS positive prep here. So you've got hyphae in the stratum corneum, very clear to see, and some underlying mild to moderate spongiosis. Stasis dermatitis is biopsied often because patients are bothered by it. They're very itchy. Clinically, what these patients have are hyperpigmented eczematous plaques on bilateral lower extremities with variable lower extremity edema. They may also have ulcers. And this is really the result of venous insufficiency. So some people call it stasis, venous stasis, but you don't have true stasis. That means a lack of blood flow. What you do have, though, is insufficient venous flow. So you get accumulation of fluid in the lower legs that puts stress on the blood vessels, that causes capillary dysfunction and leakage of blood cells, that causes a low-grade immune response, that also causes thickening of the vessel walls of the small vessels, and they proliferate and become arranged in a lobular fashion. So you can actually pick up on where the biopsy often is in patients, because you'll see some underlying venous insufficiency changes or stasis changes. Here's that classic kind of pinkish to dark purple indurated plaque with surrounding brown hemosiderin related changes in the skin on the lower legs bilaterally. Dermatologists, unfortunately, will get consulted for bilateral cellulitis all the time on this. More examples of stasis dermatitis, that acute to subacute change in the dynamics of the extracellular fluid, pushing up more towards the extracellular, the upper epidermis, causing even epidermal dysfunction and leakage of that material out onto the skin. So you can get this weeping change, and that's actually a true eczematous change right there. You can see here that it was probably very itchy and secondary excoriation on top on the right, very erythematous. If this were just on one leg here, it would be hard to say it's not cellulitis. And so you can definitely get super infection of these areas too with chronic scratching. So we'll get biopsies often to rule out cellulitis, and also to rule out other things that can mimic stasis dermatitis. So it could just be a mild capillaritis. It could be psoriasis. There's many different things that will present looking similar to stasis dermatitis changes. Now, in histopathology, as you would predict, you're going to see subacute to chronic spongiotic dermatitis. The key here, and I often like to mention it in the reports, is a lobular proliferation of small dermal blood vessels with thick walls. And so that helps you just understand that I'm seeing some stasis dermatitis change or venous insufficiency change. Even in the background of a different pathology, you can see stasis change in the dermis. You'll often see extravasated erythrocytes, and so that doesn't mean it's a true leukocytoclastic vasculitis or a lymphocytic vasculitis. It just means that the blood cells came out, or they came into the dermis from the lumen, and they're going to stay there. And eventually, this hemoglobin will break down into hemosiderin, and macrophages will come in and try to get that, and you'll see hemosiderin laden macrophages or siderophages, which are different than melanophages because melanin are within the macrophages, and that's melanophages. And so pigment dropout from the epidermis or even resolving melanoma can release pigment, and you can have abundant melanophages. But here we're looking more for hemosiderin. Hemosiderin is more of a golden brown color compared to melanin, which is a more dark brown. Hemosiderin will stain with special stains such as Prussian blue, and they'll actually stain blue after the treatment with Prussian blue. Melanin is best highlighted with Fontana Masson, which will turn the pigment black. So if there's any doubt on whether or not you're looking at hemosiderin or melanin, you're going to want to do a Prussian blue / iron stain or a Fontana Masson, respectively. Variable reticular dermal fibrosis can be seen. It's not a specific diagnostic feature. So stasis dermatitis, you'll have these proliferation of thick-walled vessels in a lobular pattern in the dermis here. You'll also see surrounding hemosiderin from breakdown of degenerated erythrocytes. You'll see some freshly extravasated red blood cells in some areas, and you'll see an overlying acanthosis. Sometimes you can just have effacement of the reedy ridges because of that chronic edema that's occurring here. And you can even have overlying basket weave orthokeratosis, depending on how long it's been there. You can also just have chronic lichenified changes. You can have more subacute changes with alternating perikeratosis. So it really just depends on which spot you biopsied on the patient clinically, how long it's been there, et cetera. More examples of stasis dermatitis with the proliferation of thick-walled vessels and scattered pigment and continents to the side of these vessels. We're getting close to the end here. I believe Lichen simplex chronicus is kind of the end stage. And so you'll see this thick lichenified tree bark-like appearance with excoriated papules. So that suggests that they are still actively scratching. Here is more advanced stage on the left, and here is more of a subacute to chronic stage. It's becoming Lichen simplex chronicus here. On histopath, you're going to see an overlap between chronic spongiotic dermatitis and psoriasiform dermatitis. And psoriasiform dermatitis will be the next lecture that I upload after this. So just to help contrast these two, but the clues to differentiate include no neutrophils in spongiotic and chronic spongiotic dermatitis, at least not usually, unless you have some overlying superinfection or overlying acute on chronic wound healing effect from fresh excoriation or an overlying fungal infection or something like that. You're usually not going to see neutrophils in mature chronic spongiotic dermatitis or Lichen simplex chronicus. Whereas with untreated psoriasis, you will see a lot of neutrophils in the stratum corneum. Hyperkeratosis of Lichen simplex chronicus, you can have intermittent perikeratosis and a loss of the granular layer, and that can resemble psoriasis. But usually with psoriasis, you'll have parakeratosis that's more confluent, as well as an underlying hypo or lack of granulosis, which is more confluent than Lichen simplex chronicus. And even with Lichen simplex chronicus, you'll usually have irregular acanthosis with overlying hypergranulosis, and like I said, 7 to 8 cell layers thick in many cases. You can see vertical collagen fibers in the papillary dermis, and remember the suprapapillary plates are not that thin in Lichen simplex chronicus either, and mild superficial inflammatory infiltrates. So again, this is not the most representative picture of a fully evolved Lichen simplex chronicus. This is kind of more in line with the picture here to the right, okay, where you're evolving from a subacute to a chronic. And so you can see some irregular hyperplasia. You can see the hypergranulosis in some areas here and the overlying orthokeratosis. But even more dramatically, you're going to have a thicker stratum corneum. You're going to have thicker granular layer. Prurigo nodularis is essentially just a nodular form of Lichen simplex chronicus. So these go by the name of Picker's nodule. One of my mentors in Miami used to make a joke that if you ask the patient if they're picking it, they say no, but you know they're picking it. Some patients understand they're picking it, but they cannot stop because it's just so itchy and it's something that they just can't break the habit, right? So this is a chronic, extremely pruritic dermatitis characterized by discrete, raised, firm, hyperkeratotic papula nodules. Sometimes patients are chronically picking at their skin for various reasons. It could be due to the effect of drugs. It could be due to the effect of a belief that there are parasites within the skin. It can be due to the fact that they have chronic pruritus of an underlying disease. There's many different reasons why a patient's going to chronically scratch at their skin. But the important thing is to rule out pathology that is related to a malignancy or some other type of pathology. So it's most of the time we're getting rule out prurigo nodularis versus SCC when it's a fully developed prurigo nodule. When it's a fresh papule, a pink papule, it's not fully excoriated, those are going to be more high yield because we'll be able to see, is there an underlying spongiotic dermatitis? Is there an underlying psoriasis? Is there an underlying interface or vacuolar or lichenoid interface change? So is there an underlying dermal pathology happening? So trying to get down to the bottom of what's causing the prurigo nodularis is sometimes important just to biopsy something that doesn't look like a prurigo nodule at all to be able to see what's the pathology look like before they evolve to this, because most of this is just due to secondary excoriation. It usually begins in the middle age population, occurs chiefly on the extensor surfaces and the extremities. You can see this in patients with atopic dermatitis. You can see this in patients with chronic contact dermatitis. Again, there's many causes of chronic prurigo nodularis. They may coexist with lesions of Lichen simplex chronicus. So you might see some prurigo nodules to the edges of a confluent Lichen simplex chronicus plaque. The cause is unknown, but predisposing factors include atopic predispositions, metabolic changes or metabolic disease, systemic disease, local trauma, so really anything. And when a patient comes in and they're new and there's no clear understanding of what exactly is going on, but it's clear that they have some areas of prurigo change, then it's important to try to harvest a biopsy from an area that's going to be less hyperkeratotic, less representative of chronic prurigo change, as I said. So here, you might be even thinking this could be a dermatofibroma, and you often get prurigo changes overlying a dermatofibroma because it's itchy. So anything that's itchy can have superimposed prurigo changes. You can have cancers that are hiding in the center of something that's a prurigo-like nodule. So many times I will see biopsies that have a central skin cancer or a central hypertrophic actinic keratosis or something to that effect with surrounding prurigo changes. Here you can see clearly that this patient's chronically scratching at their leg. I mean, to have this many skin cancers in one area would be very rare, but it's still possible. And so if the patient's never had a biopsy to demonstrate prurigo nodularis, then it's definitely helpful to help reassure the patient, hey, look, we think this is due to secondary change from chronic itching. So the treatment goal is going to be to reduce the pruritus, whatever's causing the pruritus. More examples of prurigo nodule. Now, again, if this patient had, let's say this was a patient that had one of these on the dorsal hand, I mean, you definitely want a biopsy to rule out a squamous cell carcinoma because it's really difficult to tell clinically. And as I said, the prurigo changes may be covering up a central cancer there. It's important to put on the requisition to the pathologist that, hey, we want to rule out prurigo nodule. And we strongly suspect prurigo nodule versus we strongly suspect a skin cancer based on the clinical appearance of it as well. But at the end of the day, the changes of prurigo and the changes of an underlying malignancy can mix together in such a complex nature that it's impossible to truly rule out a well differentiated squamous cell carcinoma. And so I'll often sign those out as atypical squamous proliferations and comment on the aspects of the biopsy that are concerning to me, including abundant glassy atypia and areas of endophytic architecture and areas that look suspicious for early invasion of squamous cell carcinoma, because it can truly be an evolving, well-differentiated squamous cell carcinoma. And so if it's not clearly 100% cytologically a perfect cytologically abnormal squamous proliferation, that would be in the realm of the squamous cell carcinoma, but it's got enough atypia and enough endophytic architecture, then I will comment to say that although a lot of this is prurigo nodularis, there's some areas that are definitely concerning, and recommend a conservative but complete excision to make sure you have negative margins. Sometimes excising these areas is exactly what the patient needs. So just taking this area, this problematic area from their body, and giving them a well-healed scar will actually cure them of the condition of the prurigo if it's just one area. Prurigo nodularis on histopath, as I said, you'll have dramatic irregular epidermal hyperplasia with inward pointing of the reedy ridges, hypergranulosis, vertically streaked papillary collagen. You can see the hairy palm sign, which looks like acral skin, but without hair follicles. So here is a really good example of prurigo nodularis, and actually Lichen simplex chronicus can look like this too. And so you'll have this very thick hyperorthokeratosis, you'll have this very thick hypergranulosis, you'll have irregular elongation of the reedy ridges with some vertical streaked collagen. You'll have perivascular lymphocytic inflammation and fibrosis. So this is perfect. Now, if this is a elongated plaque or a very long plaque, then this would be Lichen simplex chronicus. If it's one nodule, then it's prurigo nodularis. This is another example too of just how regular and at least on the cytoplasm here, it's not very glassy in terms of the atypia. So this is clearly a prurigo nodule and never be confused for a squame. However, though, there are some overlaps between atypical glassy proliferation. Sometimes these islands are breaking off and you see maybe a scattered mitotic figure or two with a glassy island down here, and it's transected at the base. So at that point, it becomes more worrisome because you could truly see superimposed prurigo overlying a squamous cell carcinoma. And especially if it's on the dorsal hand or something to that effect, it becomes even more worrisome to see those types of changes deeper down. But for all intents and purposes, this is a classic prurigo nodule here, and most people would not confuse this for any type of squamous cell carcinoma at all. Again, classic prurigo nodule. You see this elongation of the reedy ridge. You can see some glassy change here, but there's really no nuclei that are looking pleomorphic in this, and it just looks like hyperkeratosis here around a follicular ostia. Again, some dermal fibrosis, some inward bending of the nodule. You can see how it would be very difficult to know, are you dealing with a squame or a prurigo nodule clinically, because you have this acanthoma and it's hyperkeratotic and it's got secondary excoriation, it's got some serum containing crust. So being able to get underneath the nodule is also important if you can, to give us a holistic sense of what we're seeing. Because if you transect this thing in the middle here, it's going to be hard to know what's lying below it. And so we can really just say mostly prurigo nodule, but it's broadly transected. And so if clinical concern for neoplasm persists, an additional deeper biopsy would be recommended. Prurigo nodularis and verruca vulgaris has some similarities in terms of the inbending of the sides of the epidermis. That's called buttressing. And you can have elongation of the dermal papilla with some kind of thin suprapapillary changes, almost like psoriasis in a way, with towers of perikeratosis and papillomatous architecture, some intracorneal hemorrhage. So this is at the bottom of verruca vulgaris. It can look similar to prurigo nodularis, but usually in verruca vulgaris, you'll find some good coilocytic change. You'll find some punctate what look to be larger keratohyalin granules, but actually the DNA of the HPV virus is getting stained heavily by the hematoxylin. And, it helps clinically if they said that they suspected a verruca, because you'll often see more punctate thrombose vessels on dermoscopy, or even clinically, you'll see that as well. So this is a list of all the different features that can show spongiosis. And as I mentioned here, you can have entities such as pityriasis rosa, superficial fungal infections that can all show changes very similar to this, polymorphic eruption of pregnancy, erythema multiforme, miliaria rubria, erythema annulare centrifugum, guttate parapsoriasis, acral papular eruption of childhood, eczema, lichen striatus, insect bite reaction, prurigo nodule. These are all things that are going to show spongiosis. So you really have to get an idea of clinical here. So you see that a lot of these pictures I'm showing you have nummular configurations or annular configurations. They've got some potentially leading scale on it. It's hard to say, exactly what it is. This patient's pregnant, so you can start thinking about polymorphic eruption of pregnancy here. The first picture, you can think about PR. Second one, you can think about superficial fungal infection. And the third one, obviously, if this patient weren't pregnant, you might be thinking fungal infection. You might be thinking nummular dermatitis. You might even be thinking subacute cutaneous lupus or some other annular figurated erythema, such as erythema annulare centrifugum. So you have to really know the clinical as well and get a biopsy to help you figure that out. Now, we'll discuss in different lectures about how to work up other pregnancy-related dermatoses, but polymorphic eruption of pregnancy is very common. Here you can see, another pregnant patient. This time they've definitely got some stria, and they're probably very itchy around here. And so that could also qualify as a polymorphic eruption of pregnancy. And you could think about herpes gestationis, which is kind of in the central picture here, but can look very similar to polymorphic eruption of pregnancy, because you can have various, stages of these papules. Usually with polymorphic eruption of pregnancy, you'll see more changes of just chronic pruritus around here, development of stria, just kind of chronic itching. Whereas with herpes gestationis, and I like to remember the O in gestationis, makes me remind myself that oftentimes these lesions will be involving the periumbilical region and an O shaped here. But you'd want to definitely do a direct immunofluorescence in this patient and see if there's reactivity against collagen 17 or BPAG2, the specific subunit there that helps define polymorphic eruption of pregnancy. That helps define herpes gestationis rather. And polymorphous eruption of pregnancy is even more common, but DIF is not going to be positive there. And here, you can see these classic targetoid looking lesions, so you can definitely think about an erythema multiforme. Now, erythema multiforme can contain spongiosis, but the primary inflammatory pattern is going to actually be more of a interface change with a good amount of necrosis. So spongiosis is definitely not a defining feature by any means of erythema multiforme. It's rather a paucicellular interface, vacuolar interface dermatitis with necrosis as you go from the outer edge to the inner edge. So this would contain more epidermal necrosis in the dusky center. And as you go out, you're going to find more intact epidermis, but you're still going to see some interface change. Here's just a table summarizing different changes that you can see in spongiotic dermatitis. So as I mentioned, they share a lot of things in common, and there are a few things that can help you differentiate. So at the top, superficial perivascular lymphocytes. Well, that's in all entities, so that doesn't help you at all. If you've got deep perivascular lymphocytes, you can think about papular dermatitis, but usually in all these entities, you don't have deep perivascular lymphocytes. If you have deep inflammation, it should put you into a different category, including considering things like in the autoimmune connective tissue disease realm. We'll talk about that in other lectures. Epidermal necrosis, as I said, is more common in irritant contact dermatitis as opposed to the other entities. Seeing spongiosis around the follicle is more common in seborrheic dermatitis. Dermal eosinophils are seen in pretty much every entity, but and here I would actually change this chart to show that the allergic contact dermatitis is probably going to have more dermal eosinophils than others. So I'd put 2+ here on allergic contact, but it's still accurate to say plus or minus because you may or may not have eosinophils in all of these conditions here. Usually do not see dermal eosinophils in pityriasis rosea. Lymphocyte exocytosis can be seen in every entity, but it doesn't have to be. You can see it more in pityriasis rosea. And erythrocyte extravasation can be helpful because it can put you into a category of pityriasis rosea when you have just some subtle spongiotic change, maybe some overlying mounds of perikeratosis without neutrophils, and the classic clinical of a herald patch with a Christmas tree distribution, a rash on the back that has fine syrup paper like scale. Then you're going to be thinking of pityriasis rosea, usually in a young patient after some type of infection. Bonus information is that pityriasis rosea is usually associated with HHV 6 or 7, it's thought. But at the end of the day, it's a pretty classic clinical presentation, but the dermatopathology is somewhat subtle. So you're looking for mounds of perikeratosis with not a lot of neutrophils, or else you'd be thinking about a guttate psoriasis. You're looking for some mild spongiosis and maybe some foci of extravasated erythrocytes. Papular dermatitis is a type of dermatitis with these obviously pruritic papules. Unknown etiology, it probably is related somewhat to atopic dermatitis predisposition. Could be related to the effects of a contact dermatitis. It could even be just what we call id reaction, where you've got this non-specific eczematous or allergic type reaction around the rest of the body, separate and far away from the initial insult to the skin. So papular dermatitis has a predilection for the trunk, pelvis, and proximal extremities. Considered the same entity as subacute prurigo. Some people just call it itchy red bump disease, which is probably the most accurate diagnosis label that we have in dermatology. Pathology is focal spongiosis and perivascular lymphocytes with eosinophils. And so again, going back to this chart here, papular dermatitis, it shows that you have usually a lot of eosinophils here. So it shows that there's just allergic activity happening in the skin, causing overlying need to scratch and excoriation as well. And so diffuse pruritus in these patients. Spongiosis could be localized to the follicular infundibula as well. Here you can see examples of papular dermatitis. So again, itchy red bump disease, but you have scattered erythematous papules with some overlying excoriated changes here. On histopathology from low power, you see this superficial perivascular lymphocytic infiltrate. You don't see a lot going on in the epidermis. When you go on higher power, you'll see some mild spongiosis. In the higher power, you'll appreciate some perivascular lymphocytic inflammation and some scattered eosinophils as well. When we talk about eosinophilic spongiosis, we're referring to conditions that have a lot of spongiotic change with abundant eosinophils. In fact, the eosinophils actually are sometimes even found within the epidermal compartment itself. So this is very dramatic when we see it. There's a list of conditions that we need to think about with eosinophilic spongiosis, including incontinentia pigmenti. Pemphigus vulgaris can have eosinophilic spongiosis. Bullous pemphigoid. Now we'll get into these entities in our vesicular bullous lecture as well. Linear IgA disease, pemphigoid or herpes gestationis, as I mentioned earlier, and polymorphic eruption of pregnancy can show this. Insect bite reactions, atopic eczema, contact dermatitis, Grover's disease, drug reactions. So you can see a lot of things happen. I will mention that I did at least hit upon direct immunofluorescence testing in pemphigoid gestationis versus polymorphic eruption of pregnancy. The classic DIF is actually going to be a lot of C3 along the dermal epidermal junction. Linear C3 is pretty definitive for pemphigoid gestationis. Even though you do have some IgG circulating there. It's not as easily seen on DIF, but the C3 is prominently seen in pemphigoid gestationis. So just a little tidbit for you to prime you for the vesiculobullous lecture. So you see a picture here of incontinentia pigmenti. It's in the vesicular stage, which is the earliest stage of incontinentia pigmenti. This is due to a defect in the NEMO gene in patients, which is related to the NF-kappa B modulator. And what you see here is usually vesicular eruption that evolves into a verrucous pattern, and then or verrucous morphology rather. So you go from vesicular to verrucous, and then hyperpigmented, and then hypopigmented. Those are the 4 stages of incontinentia pigmenti. Of course, you can have pemphigus, which is due to antibodies and desmoglein, or autoantibodies against desmoglein 3 primarily, but you can have anti-desmoglein 1 and 3. Bullous pemphigoid can look also very similar, especially in its urticarial phase. But whereas here you have flaccid blisters in pemphigus vulgaris, bullous pemphigoid, you're going to have much tense blisters. And some of them have ruptured and you have some overlying erosions. But with bullous pemphigoid, you're going to have really tense blisters. And on histopath, you'll see subepidermal blister with a lot of eosinophils, classically. There are some posse eosinophilic bullous pemphigoid entities, but those are not your classics. Of course, on DIF, you're going to want to see an IgG and a C3 linearly along the basement membrane on perilesional DIF. And let's see, the other entity we can discuss, this is a linear IgA bullous disease where you have this kind of beaded round appearance around the vesicles, and that's caused actually by antibody or linear IgA deposition in the basement membrane. The actual antigen for both bullous pemphigoid and linear IgA is the same. So the antibodies, where it be IgG and bullous pemphigoid, or IgA and linear IgA disease, are really targeting the same protein, which is bullous pemphigoid antigen 2 or collagen 17 or BP180, but there's just different subunits involved. So here there is a shorter kind of like within the realm of 90 or 95 kilodalton protein that's kind of known as the LAD part of the bullous pemphigoid antigen 2. And so just understand that a lot of these autoimmune diseases are really the result of the same protein being attacked, which is bullous pemphigoid antigen 2, also known as collagen 17, also known as BP180. But the nature of the antibody itself, whether it be IgG and bullous pemphigoid or IgA and linear IgA bullous disease, that's the difference. Of course, you can have other reactions on the body, including even insect bite reactions. You can see here, this looks like the insect's been traveling around for breakfast, lunch, dinner, 4th meal, early breakfast again, early brunch, So this is probably, I would suspect that you have some type of insect bite reaction here. But of course, it's linear too, so you could think about contact in your differential as well. Of course, Grover's disease can show acantholysis and dyskeratosis looking similar to Haley or Darier's disease. So that's always on the differential. You've got these little erythematous nonspecific papules over the body of elderly gentlemen. That's the classic population. Unfortunately, drug reactions can actually cause anything in dermatology. So any inflammatory pattern is going to actually be associated with some type of drug causing that reaction. And usually if you see multiple inflammatory patterns, like a lot of spongiosis, a lot of interface change, a lot of perivascular eosinophils, you can think about a drug reaction for sure. It's truly hard to rule out drug reactions. You really have to have a high clinical degree of suspicion. But if you have just pure classic pathology representative in other disease, then of course you're going to favor that. But even with lichenoid inflammatory disease, drug reactions can cause lichenoid inflammation that looks a lot even like lichen planus without a lot of eosinophils or perikeratosis, as you would like to see in a drug-induced lichen planus. So Long story short, drug reactions can produce many clinical mimics of all of these diseases. There's a mnemonic in Dr. Elson's textbook called HAPPY for eosinophilic spongiosis, which stands for herpes gestationis or pemphigoid gestationis, arthropod bite. So if for whatever reason, arthropod bites or insect bites result in very dense wedge-shaped eosinophilic reaction. You can have focal epidermal necrosis at the site of the bite, but you won't always see that in the plane of section. Allergic contact dermatitis, as we mentioned, pemphigus vulgaris, bullous pemphigoid, and continentia pigmenti. And there's an entity in pediatric dermatology that we should all be very well familiar with, which is erythema toxicum neonatorum, where the patients will actually get small little papules and vesicles filled with eosinophils that usually self-resolves within the first couple of weeks of birth. So I will actually end it here, and we will do another lecture in a separate video to summarize the psoriasiform reaction pattern.